I'd like to welcome everybody here. This is the pediatric session. This is a presentation or a series of presentations in the very beginning. We're going to be starting out with therapy issues. And it's appropriate that we start out with neurosurgical therapy issues because typically neurosurgery is where we start with these tumors. It's what allows us to understand at a level of high certainty what the tumor type is as opposed to guessing. It's a situation which allows us to improve symptoms by reducing the amount of tumor that's there, as well as potentially make a big impact on outcome because some of the tumors that we take care of can be cured surgically alone. So the first presentation is going to be by Dr. Storm, our esteemed neurosurgeon, talking about some of the advances that are being made. We'll move from there into some of the chemotherapy issues as well as some of the radiation therapy advances. So we're a little bit behind, and Dr. Storm has a patient on the table. So we're going to start forthwith, and we'll go from there. Thanks.
All right, well, thanks, Peter. Now, most of the families will come out and see these. Don't mind seeing some intraoperative photos. So, in disclosure, there will be some intraoperative photos that if you think they might spook you, I'll introduce them before I show it so you can look away. But most of them are fine. I'd say in the last few years, there have been a couple of advances, and one has been on the clinical side, and the other has been on the research side. And on the clinical side, it's gone from doing these kind of very aggressive, very open, and most often, instances, very morbid procedures. And we're kind of coning down to being able to do them minimally invasive that are actually even more effective. And we're having better outcomes and far less morbid by using endoscopes. And then the other is on the research side of things, where we've kind of gone from small and only having tissue where one or two scientists are kind of interested in one or two genes, and now through technology and collaboration, we've been able to expand that to a point where now we can have almost limitless possibilities and multiple collaborations. So we'll start with the clinical, and what I'm talking about is, so here's a patient who was having headaches, vomiting, kind of typical presentation of a pediatric brain tumor. And this is an MRI sagittal view, so it's slicing up and down and through the middle and to the sides. And this is after contrast has been given. You can see this kind of solid tumor here that's avidly enhancing with a cystic component. They have hydrocephalus. The tumor's blocking the normal flow. And this is a patient that we would operate on a couple years ago that would need almost an ear-to-ear incision. Then you go and have to put in a catheter through the brain, drain the fluid, relax the brain, retract in, and then all the critical structures, since this tumor actually grows from below and grows up, pushes all the optic nerves, the arteries, and this way you're actually operating from above and working between them. And so there is an intraoperative photo here, which I don't think is going to bother anyone. But so what we're seeing here's the optic nerve, there's the chiasm. So these are going to the eyeballs. Here's the carotid artery coming into the head. Here's the anterior cerebral, middle cerebral, and here all this is tumor that has completely distorted all this anatomy. So we have to work, again, now the biggest concern with these is always protecting the vision. And you can see the tumors below it, so we're working between all these little corridors here, trying not to injure the optic tract, chiasm, arteries. These are all tiny little arteries that you have to protect, and it can be quite challenging. Now, these patients did well, and here's a post-op scan. The patient did quite well, tumors out, ventricles are small, but still there's a lot of retraction on the frontal lobe. There's all this air now in the brain, and if we could do it from below, with an endoscope, that would be considerably better. So this is a patient we just did a couple months ago, and now this same tumor, very similar symptoms. This is probably the largest solid craniopharyngioma I'd seen. It's going all the way back from pineal all the way to the sellar region. It's quite large, and it's displacing the midbrain here where all the motor fibers go through. So again, very similar. In fact, this would probably be impossible to take out in one sitting. I'd probably be able to get to about here and then have to do a second craniotomy and come in from the back. But what we've been doing over the last year and a half is using these endoscopes where we literally just work through the nose. So we put the camera in one nostril. We can look all the way through, way down to the skull base, inferiorly, middle, and then anteriorly. And in fact, that's what we did. So now we just put, the scope goes in one nostril, and the otolaryngologist hold the scope for us, and then I work through the other nostril, and we literally just take this tumor out from below, so you're not doing any brain manipulation whatsoever. We actually have a video of that. So the otolaryngologists open these procedures for us, and it takes several hours, but what they'll do is they're actually raising a nasal septal flap, because the concern was always operating through the nose that they would get an infection, because you're going right into the brain through the nose. But we found by raising these flaps and putting some fat from their leg and fascia from their leg, we can seal that up. So here they're just elevating the vascularized flap. They tuck it into the maxillary sinus, and now they're holding the camera in the one nostril, and I've got the instruments here in the other nostril. We're now opening the dura. And again, so no retraction. We haven't done anything to the brain. Now we're starting to see tumor here, continuing to open the dura up, exposing the tumor. Remember, all the important structures have been pushed way superiorly. And now the dura is open. Here the tumor is being removed from below. Now the optic chiasm is right here. So we're below it. All those vessels, all the extra vasculature that we normally have to peel off, it's totally protected. Everything is being decompressed from below. And we just can continue to kind of roll this thing out. And you'll start seeing in the ventricle, which now we're in the ventricle, but we're from below. We haven't had to put a catheter in it. We haven't had to manipulate it. And you'll start seeing a view of actually inside. So now there's the foramen magnum. Those are the foramen of Monroe. That's choroid plexus. And now we're going all the way back. We're able to reach all the way back to the pineal region, and just continuing to roll out the rest of this tumor. And once we get this out, like I said, we take a little bit of fat from the thigh and the fascia there to then help reconstruct this. But again, this brain has not been manipulated, it's not been stretched, nothing's been touched. And then now the tumor's completely out. There's where the sella, and that's back to the pineal region, and up there's the ventricle. So now we just put some fat in there. So there's the fat going in the fascia lata. Rotate those flaps back in, put some packing. I mean, tumor's out, there's no air in the brain, and oops. And this is the post-op. I worked through that nostril, they held the camera in that nostril, and that entire tumor's out like that. And again, here it is. This is just the fat that we took from her thigh, and the rest of her nose looks quite good. Tumor's out, and again, that was all done through her nose. And they, that night they're watching TV and asking for something to eat. This is another example of a case that I did a few years ago. Again, open, so now the tumor's a little bit lower. Again, same cut, sagittal, enhanced scan. So we've got this large enhancing skull-based tumor that there's really no good way of getting to it except through the front. And here it is on the axial. So now his eyeballs are up front, and here's his brainstem getting compressed. Again, this has some pictures in it, so hopefully it won't bother anyone. But the way we did this was, again, a few years ago, so it was more open. We didn't use the scope, but to get it, we ended up making an incision through the lip, around the chin, back, so we could split his jaw, rotate it open, to then get access to it. We also had to do a tracheostomy to keep the tube out of our way. And then this is just a view after we've done all that, and here's the tumor. So we're through his mouth, here's his tongue, so we're through the mouth, and then just drilling out above and below, basically using the same drill that we use whether we do it endoscopically. We just didn't have that ability to do it a few years ago. And there the tumor came out, and he did fine. Again, now here he's sutured back up. The tumor's out. again, some more fat so we don't get any leaking, but he got a nice result. And here he is 48 hours later, he's made his Lego helicopter, and he looks pretty good, but it would have been nice if we could have maybe spared him a bigger incision and the tracheostomy, which he got out on post-op day 8. Again, getting minimally invasive to try and limit the morbidity that these folks have. And this is one we did about 8 months ago. So he came in with a vascular tumor, and this is again axial T2, so eyeballs are up front, and then here's his brainstem, and here's that sagittal view we've been seeing. So very similar. Now, the other patient's was here, but again, all very similar. Instead of having to split the jaw and doing it in tracheostomy like we did this time, with the endoscope, we were able to just do it through the nose. And we have a video of that, where same thing, so we're in the, everything else is the same, right? The flap's been entered. Now before, there's the cella where we were operating before. Now, since we had to drill down clivus, we're drilling much lower. But, so all this, so he's holding the camera back here, and then I'm working in the other nostril over here, and just drilling out all this bone. And then, so here's the dura, and then we'll open that. And then we're much lower down, so where the optic nerve is a concern for the other one, for this one we want to watch very carefully for the artery. Now we're opening the dura, and you're about to see the basilar artery right here. And basically that artery is what keeps the brainstem and ultimately the brain alive. So there's the basilar, here's the pons. You can see a little bit of black right there. So now we're going to enter the pons. So there's just some scissors just kind of poking in there, and that's some blood we're seeing from where this vascular tumor had hemorrhaged. And then now we're just working in the brainstem, again through the nose, and remarkably these patients don't get infected. And then you just keep slowly dissecting that out. And we're doing all this with monitoring to make sure that all the motor function is being preserved. But yeah, there's the basilar, which basically divides the brainstem in two. And then that's the last piece of the mass coming out. Now you see the fat going in. You're going to put some fat in there. And then this is just a measure to put this is from his thigh, the fascia lata. And then we rotate these flaps over. And then this is the post-op scan. So lesion's completely out. And here he is 2 days after surgery, where we just operated through the nose. So that's kind of the big going small. When it's looking on the science part of the research side, it's kind of small going big. So here's our classic kind of medulloblastoma, fourth ventricular tumor that is malignant and very common, and the one that we're very interested in, this one in the low-grade gliomas. And we see, again, a few years ago, we would take this tumor and we would save it and we would process it through the lab, but it was one or two scientists, either at Penn or CHOP, looking at their one or two genes that they were interested in, and we had no way of kind of disseminating that information. And now, and again, here's post-op, so we can get the tumor out, and now we're looking at the floor of the fourth ventricle. This is the cerebellum here, looking up into the dilated aqueduct, so that's the third ventricle there. But tumor is completely out, and we turn it over to our neuro-oncology team. But now what we're doing is, so every tumor now, it's done the same way every time. We've actually recruited 3 other hospitals around the country who we've taught actually and have paid money to enable them to process it the 3 ways that we want. Then they send everything to us, and we take care of it, we analyze it for them, and then we make that data available to anyone who's participated with us online. And we've just now partnered with Penn, and they're going to start sending all their adult tumors to us as well. So the minute the tumor within minutes of this tumor coming out, it gets snap frozen in liquid nitrogen, so we can then analyze the DNA and RNA. We put cells in this media called hibernate, so that we can then grow those cells and do studies in petri dishes. And then we do a special slow freezing process using DMSO, so we can then thaw it and grow the tumor and implant it either in the flanks in mice or orthotopically in the brain. And now we have all this information that's sitting there that can be analyzed, and for genetics, epigenetics, and ultimately, of course, the goal, right, is personalized medicine. So as we're analyzing these, we can find out what's wrong and then treat them. And this is actually pictured in our lab. This is actually in the basement of where our lab is, but this is our biorepository. And this holds 2 million specimens. It's all automated. And so if somebody from Johns Hopkins is interested in something, instead of having to wait 10 years to get their hands on 30 tumors, we may have hundreds of tumors in there, and they just come in, type in what gene they're interested in, and this computer will pull out every specimen in there that has the same genetic abnormality, can deliver it, then they can go back and find out, do we have it in a mice line? Where are our cell cultures? So, I mean, this has been an exciting advance that CHOP's really invested in. Our neuro-oncology colleagues and Adam Resnick and I in our lab. And the other exciting thing is, right, so this is kind of what happens in adult tumors. I mean, you've got this normal cell, and over years, you've just got years and years of genetic abnormalities or injuries to these genes, which then can relate in hundreds of problems, meaning that it's just very difficult to figure out. If you've got 200 people, they may all have a different mutation, and there's not going to be any kind of targeted therapy that's going to work, or why it works in some and others, and it's just this kind of shotgun approach. But what we'd hope for, and is proving to be true in children, right, it's more of probably a disorder as much of development as anything else, where they're not having injuries to sun or exposure of chemicals or just a lifetime of errors. Probably just a few errors that are being done, which makes it much easier, I think, if you're looking at ability to make significant improvements. And just in part of that kind of collaborative effort, this was a paper that we published last year in Science, which was, again, a big collaborative effort between mostly CHOP and Johns Hopkins, where we sent our tumors down, we sequenced all of them, and it turned out that, in fact, there are orders of magnitude fewer. So instead of seeing 300 mutations in GBM, we're finding like 8 in medulloblastoma, which means now you're looking at such a smaller problem, which gives it much more hope that we'll be able to do that. And with the whole thing being kind of personalized medicine, and with that being able to find that gene or that targeting agent that we can go for, and then once those tumors are out, that allows us to turn it over to our neuro-oncology colleagues here and let them finish that thing off. And with that, I'll conclude and turn it over to my first Avenger here, Jane Minter.